or an autoimmune disease. You follow the protocol of treating roughly 3 or 4 cycles at each of the 3 spots on the wrist, and then 1 on the thenar eminence for the same amount of time. Don't forget to check the first dorsal interosseous, because this can be part of the problem. Also look for whether the pronator teres muscle is, has a trigger point in it, because this muscle can, in fact, entrap the median nerve at the elbow. So patient may have signs of a carpal tunnel, but the area of entrapment may be up at the elbow, not the wrist. Don't forget the ulnar nerve, because if you have a true swelling along the ligaments in the wrist, this may also involve the ulnar nerve, not just the median nerve, so you should check both of those. Splinting in a neutral position, especially at night, is important, and avoid the perpetuating factors, particularly ergonomics of the work environment. And remember that people sit at a computer terminal all day long need to have a chair with armrests to take weight off their neck muscles, as well as free up their wrists to avoid carpal tunnel problem. When we're dealing with myofascial pain, we want to look for these so-called perpetuating factors that keep on maintaining them, even though their treatment sessions may work well. By a week or 2 weeks later or 3 weeks later, the symptoms may return. If they're depressed or anxious, this may perpetuate the problem. If they have a viral, bacterial, or a fungal infection, particularly a yeast, either in the sinuses or the teeth, can be a reason for perpetuating their myofascial syndrome. Allergies that produce an increased serum histamine and allow for you to write on their skin will sensitize trigger points. Impaired sleep, especially with snoring and sleep apnea, may be a perpetuating factor, as well as what I call pain generators, which can be a fractured first toe. Can set off trigger points in myofascial pain in the neck very easily. You need to look for vitamin insufficiencies, particularly of B12 and folic acid and vitamin C, as well as iron and magnesium. Make sure you don't have any other rheumatological problem, and you may also have to deal with bruxism and clenching with splinting. If your thyroid is marginally deficient, meaning if the range for T4 is 4 to 12 and you're at 5, or your patient's at 5, this is too low to be able to get a good response to muscle stretching and reconditioning, etc. You need to be up at around 8. So a supplement with either T3 or T4, depending on what is appropriate, may be necessary. And estrogen will, you should always know if a patient is on a relatively high estrogen medication, such as birth control pills, that will stimulate the production of a antibody by the liver that will bind serum T4 and give you an apparent high level of T4 and a low TSH. Excuse me, a high TSH with a high T4 in an obese patient. Those do not go together. If T4 is high, TSH should be low. But if the T4 is bound to a antibody which will not allow it to get to the areas where it functions, but you measure it on a blood test, it will give you a falsely elevated picture. Frequent bouts of hypoglycemia can set off problem, as can patients with gout can have significant myofascial pain as well. What you want to do with these patients is return the affected muscles to normal resting length and conditioning, reducing pain to the lowest possible level. people who have what's called a postural bioimplosion, or a head-forward posture with curved shoulders, cannot be retrained. Their muscles cannot be retrained. The unstable gait, which is related to excessive pronation, must be corrected before normal posture can be restored. And that's a separate topic that we may cover at another time, as well as healing of any injured tissues. Many of these next things that I will mention will be covered in the webinars to come, or some you may have already seen. Heel pain and plantar fasciitis are frequently directly related to myofascial pain, shin splints, dorsal and or lateral calf pain due to common peroneal nerve entrapment, and patellofemoral tracking disorder, which is runner's knee, or actually it's the knee problem just about everybody, particularly teenage women athletes as well as young male athletes. They often complain of this knee pain, which is diagnosed as this tracking disorder, and it is due to an imbalance of parts of the quadricep muscle and active trigger points in the vastus medialis and lateralis muscles, which when inactivated allow the patella to get back to normal and avoid the chondromalacia. Sciatica, pseudosciatica, and low back pain are many of the other clinical conditions you'll see. Hip pain, groin pain may be related to either entrapment or referral patterns for the quadratus lumborum muscle. The latissimus dorsi muscle is one you should always check when patients with low back pain have some upper back pain symptoms, and vice versa. The muscular sling of the shoulder is a very complex problem to deal with, and you need to look at every muscle that is attached in order to make sure that you don't deal with, or that you don't miss anything that will allow the pain in the shoulder joint to continue. The neck and jaw and temple pains and headaches are frequently due to the sternomastoid muscle. Chest pain and arm pain. People going to the emergency room with chest pain going down the arm, where all of their EKGs and enzymes are normal, are most likely due to having a flare-up of trigger points in their pectoralis major muscle. Locating a trigger point, you can do that by a pincer motion and grabbing the taut band and then feeling it twitch, or you can palpate it like you would strum a string on a guitar, and again you'll find a twitch response as you run over your finger over the trigger point when it's over a bone or a solid surface. We've talked about carpal tunnel. These are some of the areas you'll see with location of trigger points as demonstrated by an X, and referral zones with the stippling and the more solid areas. This is a picture of the latissimus dorsi muscle, and you can see it is attached to almost all of the thoracic and the lumbar vertebrae, and can give you pain along those areas as well as down the arm into the fourth and fifth fingers. You can see the upper trapezii will often give you this neck pain going up to the nuchal line, as well as proximal shoulder pain. The quadratus lumborum trigger points can give you pain in the buttock along the side of the hip, but also can radiate into the groin, giving you the picture of kidney stones, or may in fact give you pain in an area which is almost identical to an L4-5 disc and is frequently the cause of an inappropriate surgical procedure. The infraspinatus is a common trigger point that frequently has to be dealt with and is difficult to get rid of easily. And you can see that the reference zones are not only into the shoulder but down to both the palmar and the dorsal hands, as well as into the interscapular area. The iliopsoas trigger point, the iliopsoas muscle, as you know, is the major flexor of the hip and is usually inactivated here down where the attachment occurs on the femur. This is the primary reference zone along the back, and one almost never has to go here to inactivate a trigger point. It's almost impossible to find that muscle to palpate because it lies anterior to the spine, and sticking a needle in here is an exercise in checking your ability to withstand stress, as the aorta and the vena cava are located right next to that muscle. And obviously you don't want to put a needle into either of those structures. This has been a fairly quick, but I think a very important covering of the topic of chronic pain, and in particular the role of myofascial pain in that in the development of chronic pain syndromes. If you have a specific question about it that is not either a long case report or a question about a case, but might be applicable to a lot of the people attending the webinar, please just type it into the chat box on the right, and we'll try to answer those. We have other questions that have been asked at some of these, and we will attempt to raise those questions and have them answered. And if you have any either personal questions or case questions that you'd like answered, don't hesitate to email the question at the address, which we will give you in a moment, to request some information and answers. Here's some reference. The most important one is the Travell and Simons books, known as Myofascial Pain and Dysfunction, the